Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on polypharmacy and cardiovascular risk considerations in older people with HIV, featuring Jonathan Appelbaum, the Laurie L. Dozier Jr., MD, Education Director, Professor of Internal Medicine, and Chair of the Department of Clinical Sciences at Florida State University College of Medicine in Tallahassee, Florida, and Jens Lundgren, Professor, Riggs Hospital, University of Copenhagen, and Director of the Center of Excellence for Health, Immunity, and Infection at University of Copenhagen in Copenhagen, Denmark. They'll discuss key considerations for the use of ART in older people with HIV, including current data and recommendations on polypharmacy, drug-drug interactions, drug-disease state interactions, and cardiovascular risk considerations. Following their dialogue, the faculty will field questions from healthcare professionals. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Drs. Appelbaum and Lundgren.
Thank you, Jessica, and welcome everyone this afternoon. And really to set the stage for what we're going to talk about this afternoon, I just want to show a few demographics about the population we're discussing. So this is a slide that shows, as of 2018, the prevalence of persons living with HIV in the United States. And you can see that more than half of all of our patients are over the age of 50. And this is a rapidly growing segment of the population, partially because of the success of antiretroviral therapy as our patients are aging. And unfortunately, a little under 20% of all new infections are still happening in persons over the age of 50. This is just a review of the international guidelines, the DHHS, IAS USA, the EACS from Europe, and the WHO regarding first-line ART. The good news is most of the guidelines have coalesced around a few regimens, predominantly integrase-based. And then just some information about how our older patients living with HIV do virologically when we start them on ART. And retrospectively, looking back at a number of trials, some going back a few years, really showing no difference at either 48 or 96 weeks in most of the trials as far as efficacy in the patients over the age of 50 living with HIV compared to a younger population. So with that, we're going to first start talking about polypharmacy, drug-drug interactions, and drug-disease interactions. And I'm going to start with a case. So this is a 75-year-old male who comes into the office for follow-up. You've been following him for a while. He's been living with HIV for 25 years and is currently on a fixed dose regimen of bictegravir, FTC, and TAF. And he's been on that for about 3 years. And like most of our older patients living with HIV for a number of years, he had been on multiple antiretroviral regimens over the years. And as new drugs became available that were easier to take and better tolerated, he switched. The fortunate thing about this particular patient is he's had no documented virologic failure. He's on a number of medications for comorbid conditions, including atorvastatin for his elevated cholesterol, aspirin to prevent coronary disease, 3 drugs for his hypertension, lisinopril, hydrochlorothiazide, and amlodipine. He's on omeprazole for GERD, 2 drugs for his diabetes, metformin and glipizide, and he takes calcium carbonate for his bones, a multivitamin, and then he takes over-the-counter diphenhydramine for sleep. His exam is normal, and on the right, I've listed some of the parameters. He is virologically controlled with an undetectable viral load, CD4 count of 534. He is HLA B5701 negative. Blood pressure is good, and his A1C is good, but you can see he's mildly overweight with a BMI of 28.5, and his total cholesterol is above a target of 201. He also has some liver function abnormalities, mildly elevated ALT, and quite common in our older patients. He has a reduced renal function with an eGFR of 44, indicating stage 3 CKD. So I'm going to toss this question out to my co-moderator, Dr. Lundgren. Jens, do you have patients similar to this in your practice?
No, absolutely, John. This is, I think, a very standard older patient where the problem is no longer really controlling HIV, but rather how to make sure that we treat that patient for anything else that is happening. I guess really the point here is not only the co-medication and how to make sure that works well with the HIV medication. In particular, I guess, his slight obesity and his somewhat reduced kidney function that we need to pay attention to, but a very common patient, I would think.
Yeah, and I think it's the same here across the pond, that oftentimes it's not so much the HIV that's the issue, but it's the comorbidities that are going along with aging and HIV that can be the real challenge. So the Health HIV has conducted an annual survey of the state of aging with HIV. And the second survey results were just presented this fall. This is a survey of older patients living with HIV. Included just slightly under 500 patients who responded to the survey. And we're not going to go through the entire survey, but some of the interesting points were that most of the patients who answered the survey were taking ART, and a great majority of them, 94% of them, had achieved virologic suppression. Yet they were still concerned about the development of virologic resistance. Some of this may be because of their concern about having been on multiple regimens in the past. And a third of patients are interested and are concerned about side effects from their medications. Most of the patients rated their physical health rather low on a scale of 1 to 10, 10 being great and 1 being not so great. It was a 3.4. And the reason for that is that these patients, many of them had one or more comorbidities, 60%. And some of those comorbidities included elevated cholesterol, hypertension, arthritis, neuropathy. And interestingly, 81% of these patients were taking some sort of medication for a chronic condition. And even our patients who are uninfected with HIV, 40% are using some sort of alternative or holistic therapy, something we need to be aware of. Over half used a retail pharmacy, about a quarter used mail order pharmacy, and scattering of other places to access their medications. And looking across the world, not surprising, the comorbidities of our older patients living with HIV are very similar, including diabetes, dyslipidemia, renal disease, cardiovascular disease, metabolic bone disease, respiratory disorders, and cancer. One of the things that as geriatricians we're concerned about is polypharmacy. So taking multiple drugs increases the risk of drug-drug and drug disease interactions. And also not only polypharmacy, but drugs that may be inappropriate to use in older patients. So a study of persons living with HIV in the United States who were 65 years of age and older, and 112 of them were surveyed, 87% of them had an undetectable viral load. But if you look at the number of these patients who were taking 5 or more medications, 95% were taking more than 5 or more medications. And if you take out the HIV drugs, which can certainly add to that number, 84% still were taking 5 or more drugs at the same time. In this group, the average number of medications was 12.3 medications, including 9 non-HIV medications. And the risk of serious drug-drug interactions in appropriate prescribing is shown below, depending upon which of the criteria you're using to determine inappropriate prescribing. So there are 3 major criteria that are used: the Beers, the Stop, and the Start. I think most people know about the Beers criteria. It's probably one of the more common lists of potentially inappropriate drugs. So even if you use the Beers criteria, almost half these patients were taking at least one drug that were on the Beers criteria. If you use the more stringent Start criteria, it was up to 80%. 63% of these patients had potential drug-drug interactions. And interestingly, a quarter of these patients, or almost a quarter of these patients, were prescribed medications using an incorrect dose, perhaps medications that need to be adjusted for renal function. So what are the potential consequences of polypharmacy? Lots of things. If a patient has a side effect or a problem with the medication, they're probably not going to take it. So you have adherence issues. drug-drug interactions, which may be underappreciated or even overappreciated. For instance, many antidepressants we find are actually underdosed because of concern about an interaction. Increased risk of adverse drug reactions, so overlapping adverse events, and something that we don't like to do, which is to treat a side effect or an adverse event with yet another medication, initiating a treatment cascade. Drug-disease interaction, where one medication will worsen another condition, and the whole issue of having a reluctance or lack of inertia to deprescribe medications that may no longer be providing benefit or no longer helpful. So the guidelines actually offer some suggestions, at least around ART, to either reduce side effects or drug-drug interactions. And the switch strategies that we recommend are, number one, you want to maintain virologic suppression. So generally switching within class tends to be okay, particularly if you're using drugs if you switch to drugs within a class that are highly potent. Switching outside of a class is something that needs to be done carefully. You always want to make sure you switch from a drug with high barrier to resistance to another one equally as high of a resistance to resistance. And then there's some ways to de-escalate ART. So if a patient, has no past history of virologic resistance and are doing well on a 3-drug regimen, we might consider 2-drug regimens as long as they don't have any contraindications to that. Switching to boosted PIs plus 3-TC when you want to get rid of either the tenofovir compounds or abacavir is something else to consider. We now have the option of long-acting ART as an option in some patients. The caveat to all of this is that we have very limited data for patients who have had complex underlying resistance, multiple episodes of virologic resistance. The VA cohort study looks at common non-ARV medications for the potential for drug-drug interactions, and they list the drugs in each class that are most commonly prescribed. I mean, the good news is that on many of these, for instance, the antihypertensives, there's very little drug interactions with HIV medications. We have to be careful about the medications used for elevated cholesterol. And so we really stay away from simvastatin because of the potential for an interaction with boosting agents. But atorvastatin, pravastatin are certainly safe to use. And then finally, this is a nice chart that looks at the potential drug interactions between very commonly prescribed medications, some of which are over the counter. The big one, I think that we as prescribers need to be aware of, since most of our ART regimens are integrase-based, we need to be careful about divalent cations, so the magnesium and iron that may be in multivitamins, obviously iron pills, and then calcium-containing antacids should not be given at the same time as integrase inhibitors because of a potential interaction. With boosted atazanavir and rilpivirine, we need to be very careful of dosing with PPIs. Something we don't consider is drug-disease interactions. So the big one in our older patients is renal impairment, and remembering that some of the ART medications do need to be renally adjusted. Tenofovir should be dose adjusted if the creatinine clearance is 50 or less, or switching to TAF, which will allow you to continue to use down to a creatinine clearance of 30. The exception, it still can be used in hemodialysis. Most of us know about abacavir and not being used if a patient is HLA-B5701 positive. The good thing about abacavir is it does not need to be renally dosed. And FTC and 3TC, most of us who've been doing this for a while find that these are very well tolerated drugs, even with minimal and severe renal impairment. But there are guidelines to renally adjust these. What oftentimes we don't consider is the impact of hepatic involvement. And generally, if you have very mild hepatic impairment, you don't need to adjust ARVs. There are some exceptions which are listed here for combinations that we tend to use less frequently now. But as the hepatic impairment becomes increased, we have to be more concerned. But the good news is that there are many drugs that, or there are some ART that don't need to be adjusted, even with severe renal impairment. So getting back to our patient, a couple of things that I will make some comments on. The good news is that his blood pressure is at goal, and he's on 3 antihypertensive regimens. One of the first things I might want to do is try to see if we can consolidate his antihypertensive regimen. So the lisinopril and the hydrochlorothiazide can be combined into one pill. That will help the pill burden. It's not going to decrease his polypharmacy. Making sure we advise our patient to take his calcium and his multivitamin at a different time than his ART. I would be really careful about monitoring his renal function and consider perhaps thinking about trying to take the tenofovir out of his ART if at all possible. I would consider reducing his diabetic medications. One of the concerns is that in an older patient is that the risk of hypoglycemia may actually be more than the risk of hyperglycemia. And plus, as a geriatrician, we really don't like to use sulfonylureas in our older patients because of the increased risk of hypoglycemia. I would screen his medications using the Beers criteria for potentially inappropriate medications, one of which is the diphenhydramine. Antihistamines are highly anticholinergic and will increase the risk of falls in this patient. And he does need some evaluation for his elevated transaminase. So with that, I am going to turn this over to Dr. Lundgren.
Thank you very much, John. Really appreciate it. So I'm here to talk to you a little bit about cardiovascular risk management. And to introduce this topic, let me introduce you to Mrs. Smith, a 58-year-old woman diagnosed with HIV more than 20 years ago. Similar to the other patients, she has been on multiple ART regimens and is currently receiving the Rinavir boosted with the Cubicet together with the lamivudine and the Abacavir. She is known to have type 2 diabetes, diagnosed 5 years ago, is a heavy and ongoing smoker, 15 to 20 cigarettes, equating over life to around 30 pack years, is luckily not infected with hepatitis B and C. And you can see on the right side, the lab parameters at the visit, again, well controlled. Obviously, is HLA B5701 since she's able to tolerate the Abacavir for quite a while. Slightly overweight, slightly elevated blood pressure. Cholesterol is not absolutely terrific. You can see that the ratio of total to HDL, the cholesterol is way exceeding the 4.5 ratio. Slightly elevated ALT, have a reasonable kidney function, and have just a marker of diabetes. So complex patients with multiple issues identified in history as well in the laboratory evaluation. So John, what can we do as healthcare professionals, and what is the patient able and willing to do? I think these are critical questions because, as you say, this is not only about changing medicine, but actually have a holistic discussion with the patient herself to make sure we align our efforts. What do you think?
Yeah, I think this is a case where you need to sit down with the patient and talk about what their goals are, what their goals of care are, and also to let them know that there are things that they can do to improve their health care, that the entire burden doesn't fall on us as the healthcare team. And I think you're going to get into some of the things that the patient might be willing to have a discussion and help their overall care. And I think you need to be frank and talk about, really what the risk is, and maybe even using numbers to educate the patient.
Exactly. So thank you for that. I agree totally. You need to spend some time here. And one of the things you can do is that you can try to estimate the patient's risk of cardiovascular disease over the next, say, 5 or 10 years. This is how it is using one of the risk equations that is out there. And for example, the underlying risk of a myocardial infarction over the next 5 years is 18%, 29% over the next 10 years. So it's a sizable risk. She's on Abacavir, which we know is associated with excess risk of cardiovascular disease, which is really impactful because the underlying risk is already relatively high. As you can see, it almost doubles. And the puncher here is, of course, if you see on the right side, if you are able to all the modifiable risk factors, if they become well managed, so blood pressure, cholesterol, smoking, then the 5-year risk of myocardial infarction drops quite strongly from 18% down to 3%. So that, I think, would be a helpful number to at least start a discussion with the patient around, not because we need to go into details about all the different numbers on the screen, but at least to have some quantification of what we are talking about. We need to understand as well that stroke, in addition to coronary disease, is a risk factor in this patient. We know that the hemorrhagic strokes and the ischemic strokes, hypertension is a risk factor for both of them, but in particular for hemorrhagic stroke, as is age, older age, whether people have been previously experiencing low CD4 cell counts, and obviously people with prior cardiovascular events, and also smoking, both prior CVD events and smoking, fairly strong risk factors for ischemic stroke. So I think that needs to be talked about as well. And then the question is about antiviral treatment. The DAD study published a couple of years ago, the results on trying to associate various protease inhibitors with the risk of cardiovascular disease. It's a large prospective study. Over 1,000 events was assessed. And what was quite striking there was that the 5-year risk associated with using a ritonavir-boosted darunavir regimen was around 60%, whereas there was no signal for such an association if atazanavir was used instead. So this suggests that there is an accumulating risk over time by using darunavir, which the patient was on. And the IS-USA guidelines recommended switching from abacavir-based or PI-based regimens, except for atazanavir in patients with and without high risk of cardiovascular disease. I realize this is observational studies, but we need to be updated on the latest result on that. Recently, at the European AIDS Clinical Society Conference in London, the RESPOND Consortium, a contemporary cohort of patients, again, around 30,000 people followed for over 6 years. The abacavir question was reassessed in this separate cohort from previous studies. The same signal was identified around the 40 to 60% risk, excess risk by using abacavir, again, linked in particular to people at elevated risk. So that's an important aspect to be aware of when you consider what ART regimens the patient should be on. I think another study that is important to be fully aware of is the TANGO study that took patients who was on a 3-drug regimen that included TAF, and then they were randomized to either continue to use that regimen or switch to a simplified regimen of dolutegravir and 3-TC. On this slide, you can see the virological outcomes at week 48. So very compatible numbers. Most people obviously was maintained in viral suppression, regardless of which of the regimens that they were on. Importantly, if you switch to a 2-drug regimen of, for example, dolutegravir 3-TC, you need to be very careful if people have archived the resistance, in particular against 3-TC, as that may compromise that regimen and should not be used. Importantly, from a metabolic point of view in TANGO, what was quite striking was that if you move people to a 2-drug regimen of dolutegravir and 3-TC, in particular, if you were switching away from a regimen which was a boosted regimen, you can see a fairly sizable improvement in cholesterol levels, as you can see in the middle of this slide. This was not really seen in people on unboosted regimens, but of course this patient was on a boosted protease inhibitors, and therefore you could expect to see an improvement in cholesterol by switching away from that regimen as well. They also in TANGO looked at the glucose metabolism, looked here in terms of A1C changes, fasting glucose or fasting insulin changes at week 48. The changes for A1C and fasting glucose was minimal and was compatible between treatment arms, but there was a trend that fasting insulin favored switching to dolutegravir and 3-TC as opposed to continue on a TAF-based ART regimen. in the boosted subgroup as well. All right. One thing that the European AIDS Clinical Society guidelines is focusing on, as are other guidelines, is how to handle the smoking issue. Note the guidelines, European guidelines, you can download them as an app, so you can have them on your iPhone. But in relation to smoking, please remember to continue to ask the patients you see in your clinic whether they are an active smoker, and if they are they willing to smoke? Are they motivated for doing that? For the latter question, it's of course critically important to make sure we fully remember the issues around smoking and HIV, which includes that in cohorts of patients being HIV positive or negative, in particular among smokers, that there is an effect of the HIV status on that. So for matched people, positive or negative, the risk of cardiovascular risk is increased if you are HIV positive, which means also that the impact of smoking is more sizable, you can say, in HIV positive. Not that it's okay to smoke if you're HIV negative, but the impact for this particular woman here from stopping smoking, the smoking will be quite impactful on her overall cardiovascular risk profile. An important point, I think, to remember and be able to talk about. I think the other thing that we sometimes tend to forget is that sometimes the cardiovascular risk is really a man's issue, and therefore we may neglect some time to consider that in HIV positive women. There was a study from the DAD cohort published a couple of years ago that was able to, in real life, to show that prescription patterns was unfortunately lower for otherwise similar type of women compared to men. So just as a reminder to have that in your reflections as you see these patients. Now, what are the targets for her, for what we should aim for in terms of prevention of cardiovascular risk? First of all, we need to establish the 10-year cardiovascular risk. You do that annually, and everybody above 40 men and more than 50 years of women. Of course, advise on diet and lifestyle as you would do in any person, and then consider ART modifications if the 10-year cardiovascular risk is more than 10%, which it was in this particular patient. And again, you can consider various changes in the ART. We have discussed that already. I think what is really important is to have some target values for blood pressure, glucose, and lipids in mind, which at least according to the EACS guidelines are stipulated here on the bottom of the slide. Systolic blood pressure lower than 130, A1C between 6.5% and 7%. If people have no prior cardiovascular disease, lipids should be for LDL less than 70 milligram per deciliter. If it is a person with prior cardiovascular disease, you should try to get the LDL levels even further down to less than 55 milligrams per deciliter. One thing already alluded to is use of antihypertensive agents. I think these figures is really helpful. Either you can look them up or you can look at the websites who can also more personalized describe potential drug interactions. And of course, what we need to remember is that the calcium blockers are potentially interfering with boosted regimens, and also beta blockers can be interfering. So again, this is just a reminder of that. Another thing that I think was also alluded to before is we need to be aware that although there's a lot of different statins out there, are we actually prescribing the right statin in the right dose to each of the person that we are treating if we don't have the lipids under full control? This is a study from Switzerland of people with HIV from the Swiss HIV cohort studies receiving a prescribed statin and a concomitant antiviral treatment. And quite remarkable, statin was underdosed or use of a low intensity statin, which resulted in a suboptimal response in 41% of statin prescriptions. So it's really something that you can potentially look at and make sure that you are evaluating whether you're giving the most optimal statins. You can see that this was a problem in particular in terms of underdosing. It was a particular issue for the pitavastatin. So just a few key take-home messages. Polypharmacy requires careful consideration of possible drug-drug interactions. Make sure you consult with guidelines or online tools that can be helpful as a reminder as you either are seeing a patient who's already on medication, and certainly if you're prescribing other medication. In terms of prevention of cardiovascular disease, try to avoid boosted darunavir and also using abacavir, which is associated with increased risk of cardiovascular risk and markers hereof. You can use potentially dolutegravir and 3-TC by itself. It can be combined with TAF. TAF, it's still being debated which one of those are the most optimal. But remember, if you go to a dolutegravir 3-TC regimen, make sure that there's not any archive-resistant virus against living with it. Smoking cessation and management of hypertension should coincide with HIV care. So we focus on the totality of risk factors more so than the medicines that we are prescribing ourselves. So I think on that note, John, I'll turn back to you to moderate the discussion. Thank you.
Great, Jens. Thank you for that nice overview of cardiovascular risk in our older patients living with HIV. So we actually have a number of really good questions in the chat. So I'm going to go ahead and read them. And I may butcher some of your names, but I apologize. So this is from Sumaya. She said, or he says, that I'm a geriatrician, not an infectious disease specialist, but this case feels very similar to me as I live in an area where we have quite a few aging patients with HIV. Now, the question is, do you feel that co-management between geriatrics and ID is optimal in this situation, or do you feel geriatricians in areas with higher rates of patients living with HIV should be able to know the basics of ART therapy, as the vast majority of these comorbidities fall in the geriatrics and primary care realm? So did you want to answer that, or I can answer it? I don't know how you want to do
No, just to lay up, because I think you're a pediatrician and I'm an ID physician, so it's actually a good dialogue, right?
It is a great dialogue. So certainly in the United States, we don't have enough geriatricians, and I doubt if we ever will. So to say that the geriatricians alone should be managing older patients living with HIV, there won't be enough geriatricians to do that. I think that it's great if geriatricians have some basic understanding of caring for patients with HIV, because quite honestly, most of our HIV patients living with HIV now are fairly easy to manage on these regimens. And the person who asked this question is really correct in that many of the conditions that we're just talking about are really within the realm of geriatrics. I think anytime you can have a partnership between specialists caring for patients, I think that's great. I think in the best world, yes, both should be caring for these patients, but I think the reality is that's probably not going to happen.
And I guess I agree with that totally. I mean, I think there's two parameters here I think is really important. It is, how many people do you actually have in your care? How much is this something that is part of your everyday work life? So if you see a lot of HIV patients, you obviously is reading up on all the HIV aspects and is fully aware of that. But if you only see a few, you want, I think, to consult and have an ID physician to also see the patient. So I think your experience on how much you are up to date, I think is important. And the other thing I would argue as an ID physician is that sometimes these things can be more complicated, particularly the viral aspect of the disease. So you want to make sure you have an ID physician in your back that can help you in those situations. But I mean, caring for HIV patients is a multidisciplinary team.
Great. And we have two. I'm going to combine these questions. So one of them is about recapping the interaction between statins and protease inhibitors. And then the other question, which is very similar, would you reduce the dose of atorvastatin or rosuvastatin when combining with the PI boosted with ritonavir?
You want to take that, John? Are you more into this?
I'd be happy to do that. The interaction is really because ritonavir and cobicistat are potent P450 inhibitors, And the issue is that some of the statins are metabolized through that pathway. And the ones that are metabolized through the pathway, you can get increased side effects, including liver issues and rhabdomyolysis, among other things. So the ones if you have a patient on a boosted PI, the two that you want to avoid are simvastatin and lovastatin. And the way I look at this is that if you look at at least the American Heart Association, American College of Cardiology recommendations, neither of those two are on that list anymore as far as being potent statins. So you're generally going to go with either atorvastatin or rosuvastatin. Recommendations are, if you're going to start atorvastatin and you have a patient on either ritonavir or cobicistat, you start at a low dose and work your way up. Pitavastatin, which Dr. Lundgren mentioned previously, is actually free of drug-drug interactions, although it's not as potent as either atorvastatin or rosuvastatin. So that's my answer. I don't know if you agree, Jim.
I agree. And I think that's where I guess I would just reemphasize also what is the target here and make sure that you try to get to the targets, but not only by using statins, but also if you can to change lifestyle factors and maybe lose your weight a little bit. That all also help, I think, in some people to get their cholesterols looking better.
Okay. Given the patient profiles, this is from Francois, how high is your concern about markers of hepatic health? We didn't really get into the liver with these cases.
But you mentioned on one slide, didn't you?
Yeah.
People on child-group A, B, and C, and which drugs to use in that situation. I have to say that the liver needs to be quite sick before, and it's really typically people who have excessive alcohol consumption and have liver cirrhosis and something of that nature, or people with viral hepatitis, which typically some patients that you also are potentially co-managing with hepatologists that can help you to guide through that. It becomes a little bit more complicated. What do you think?
It definitely is more complicated. And here in the United States, I think we're seeing a lot more non-alcoholic fatty liver disease. And so that should be part of the evaluation, obviously.
Absolutely.
Asking about alcohol and also screening for viral hepatitis. All right. Among patients with HIV encephalopathy, what are your recommendations for patients without a history of resistance? Are recent integrase inhibitor combinations more or less effective than non-nukes like efavirenz? I think he's getting at the crossing of the blood-brain barrier.
Yeah, but also the word effective here, I guess we're talking about side effects really here, or I assume that is the case. Or are you thinking about penetration of?
I don't know. It could be penetration or it could be around side effects too. I think probably we should address both.
Yeah, I think in terms of making sure that we treat HIV encephalopathy, I would argue that the integrase inhibitors can be quite easily used in that situation. But there is a lot of discussion around exactly how big of a problem this actually is in terms of uncontrolled HIV in that compartment, as long as you have control in the peripheral compartment measured by plasma. So I wouldn't say that that integrase inhibitor combinations are less effective, but I would rather argue that you should try to maintain peripheral control. And of course, if the patient have HIV encephalopathy, make sure that you actually are also working the patient up for other reasons for why there is a potential cognitive impairment. There's multiple reasons, in particular in older people, other than HIV encephalopathy, that can explain that, I would say.
Yeah, I would agree. And I would just say that as long as I've been taking care of patients with HIV, which has been a long time now, we have had this whole argument about what are the appropriate drugs to get into the CNS, and does it really matter what the CSF levels are? And I don't think that question has been answered yet.
It's very confusing literature, I have to say.
Yep.
But make sure you get your peripheral HIV viral load suppressed, right?
Absolutely.
I mean, that's something everybody can agree on.
Yep. Okay. Is TAF associated with a lower risk of proteinuria, and would you avoid it in patients with proteinuria?
No, I think it looks like, at least compared to tenofovir, that it has a lower risk of renal complications, and they're including proteinuria. So I think it really, the second part of the question, would you avoid in patients with proteinuria, would say no if you actually use tenofovir in a patient with proteinuria, I would probably, in particular, if the eGFR is starting to decline, I would probably switch them to TAF to try to protect the kidney function. That would be my sense.
All right.
What do you think?
Yeah, I agree. My sense would be if I have a patient, an older patient with proteinuria, it's a marker for renal disease. If there was any possibility of getting that patient off any tenofovir-containing medication, I would. Now, if they need to be on it to control the virus, then we deal with that. But,
exactly.
All right, few more questions. I'm not sure we're going to be able to have time for all of these. What value do you think that long-acting regimens will have in older populations with adherence concerns? Talking about long-acting cabotegravir rilpivirine or islatravir doravirine.
Yeah, I think that's a good question. I mean, I think when we talk about adherence, I mean, obviously, if you have a long-acting adherence, is also that you need to come into the clinic every month to every 2 months to get your injections. So, as a consequence, I think very few people is actually using long-acting at the moment. So, at least in my clinic, I would argue this would be on very selected people that you would be considering long-acting. It is quite complicated, I have to say, both for the patient and the clinic to handle this.
Yeah, and I agree with you, and I don't think the answer is in on that. We do know that older patients tend to be more adherent with their regimens to begin with than younger patients. So, but I don't know the answer to that one yet. I think we have time for maybe one more. Let's see. There's one on smoking. For smoking surveillance and reporting, should we consider vaping, and should we distinguish it from standard smoking?
I certainly think we should distinguish it from it, but that wouldn't mean that we should say that you can go on a vapor as opposed to regular smoking. So, but I think it's still associated with excess risk of cardiovascular disease as well as containing carcinogens, and therefore something you should try to see whether you can back away from.
Thank you to Drs. Appelbaum and Lundgren, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.